Thank you for the opportunity to join you this morning and talk about radiation options for kidney cancer. So today we'll learn about radiotherapy, how it's delivered and used in the treatment of both localized as well as metastatic kidney cancer. So to start, what is radiation oncology? So radiotherapy has been used for over a century as an effective tool to treat cancer. About half of patients who are diagnosed with cancer would benefit from radiotherapy at some point in their cancer journey. Mechanistically, radiotherapy consists of ionizing radiation. So here's an image of a linear accelerator, and we can see here a physician, a physicist, radiation therapist setting up a patient for their treatment. Our technology enables us to target the radiation to the tumor, and this ionizing radiation sets off a cascade that damages the DNA of cells and preferentially picks off cancer cells, which have limited ability to repair their DNA compared to normal tissues. All right, so the physical targeting of radiation therapy has come a long way in recent decades, as you can see on this slide. So we start on the left. This is old school radiation therapy, treating based off of X-ray films. You typically have two beams, one coming in from the front, one coming in from the back. And so this resulted in really large treatment fields. And so when the radiation oncologist has a really large treatment field that has a lot of normal tissue in it, our response is to break the radiation into little bite-sized pieces that the normal tissue can tolerate better. But that results in, treatment courses that take several weeks of radiation. As we move down to the right, we then had 3D conformal radiation. So this is a little bit more of a four-field box. And then today we have IMRT, or intensity modulated radiation therapy, or even SBRT, stereotactic body radiation therapy, which allows us to have highly targeted, high amount of radiation per treatment, where we can spare the normal tissue and deliver our treatment courses in less than 5 treatments. So as you'll see on the next slide, this evolution of technology has proved to be critical in the management of kidney cancer. So historically, kidney cancer was considered to be radioresistant based on laboratory data and mouse data and clinical trials that we had in the 70s. And those essentially showed that our standard dose of 2 gray per fraction was not effective in the treatment of this type of cancer. When SBRT came along with this high dose per fraction and this steep dose fall off that doesn't give a lot of dose to normal tissue, we learned that kidney cancer is radiosensitive if you use the high dose per treatment. And so as you can see to the right, this evolution and how the radiation therapy is delivered launched a series of investigations and a renaissance, if you will, of the role of radiotherapy in the management of kidney cancer. So we're now developing a better understanding of the biological underpinnings of this efficacy and potential routes of synergy with other targeted therapies or immunotherapy. All right, well, this has decided to go through all my slides rather quickly. We'll just back up for just a moment here. All right. So one of the seminal studies that proved that radiation or SBRT can work for localized renal cell carcinoma was the data from the IROC consortium. So this was a large retrospective series from 9 institutions where providers collectively pulled data for 223 patients who had already received this form of treatment. About half of the patients received their treatment in a single fraction and about half received multifraction, especially those who had large tumors. So remember, the radiation oncologist maneuver to having a large tumor, large field, is to break the radiation into smaller pieces while still trying to have the same biologically effective dose or BED. So this study showed strong local control. You can also see high cancer-specific survival. And we also see that, importantly, there were very few patients who experienced a high-grade toxicity. All right, so fast forward to present day, we now have 15 prospective trials that have included 309 patients that show local control rates ranging from 75 to 100%. The largest of these studies was the Fast Track trial. So this was a non-randomized trial of 70 patients who had declined surgery or were not candidates for undergoing surgery. The dose to the tumor was already specified based on the tumor size, and we can see at a median follow-up of 3.5 years, they showed 100% local control, 100% cancer-specific survival, and very minimal impact on renal function, and again, very low rates of high-grade toxicities. So as we talk about the variety of treatment options that may be offered to patients, this image helps highlight the context where various treatments may be used. So radiation is a nephron-sparing therapy that may limit the decline of renal function given our precise targeting. SBRT avoids the need for general anesthesia. It can be used in perihilar tumors. It can be used for large tumors, and it is a non-invasive treatment modality. All right, so next we'll talk about SBRT for metastatic renal cell carcinoma. So metastasis-directed therapy, or MDT, applies focal or local treatment to a specific site where the cancer has spread. So SBRT can be used for either treatment of the primary when it's located in the kidney or towards the metastases. The leading scenarios where we are studying SBRT for metastasis-directed therapy are MDT instead of systemic therapy in oligometastatic disease, or to help delay a change in systemic therapy for oligoprogressive disease. Using it for reduction of the total number of cells, sometimes in lieu of a cytoreductive nephrectomy, to help prompt an immune response, or to help palliate the symptoms that our patients are experiencing from their cancer. All right, so the oligometastatic paradigm refers to the concept that amongst patients who have limited disease, we typically say this is 5 or fewer lesions, that by treating the sites where the cancer has spread, we can offer a benefit to cancer control with or without the addition of systemic therapy. So shown here is data from Dr. Tang's group. So this study evaluated definitive RT to all sites of disease as a tool to delay the start of systemic therapy and the side effects that were discussed that come along with those drug therapies. So this was a single-arm phase 2 study that included 30 patients with clear cell renal cell carcinoma and had a prior nephrectomy and now had oligometastatic disease. They irradiated all of the sites of disease, and the median progression-free survival, as shown here, was 2 years with relatively low toxicities. There was a similar study from the group at UT Southwestern, which showed similar results, and we are now awaiting the data from the SOAR-3 trial, which compares SBRT versus systemic therapy with an endpoint of overall survival. All right, next we have the oligoprogressive paradigm. So these are situations in which patients are currently on a given systemic therapy, and most of the disease is well controlled, but you have a few lesions that have managed to become resistant, and they are growing despite the continuation of the systemic therapy. So in this setting, we can offer SBRT that is targeted just to the sites that are growing while maintaining the patient on the same line of systemic therapy that they're currently tolerating. Now, why is this important? It's because as you go down the lines of drug therapy, typically the duration of response goes down, the efficacy goes down, and the side effects tend to go up. So here I'm highlighting 2 studies that were designed to include patients who were on systemic therapy. One of these was limited to patients who were on TKIs. The other allowed various lines of systemic therapy. And for patients who were experiencing disease progression at limited sites, they offered radiation to all of those sites. And both of the studies showed strong local control. It also showed that they could prolong the efficacy of that systemic therapy for about another year, and again, with minimal toxicity from the radiation therapy itself. We are currently awaiting the data from Extend OP, which is a randomized controlled trial of radiation to oligoprogressive sites with the same systemic therapy versus going ahead and switching to that next line of systemic therapy. All right, so as our medical oncology colleagues noted, immunotherapy takes the brakes off of the immune system and enables increased recognition and elimination of cancer cells. All right, so where radiation fits in nicely with immunotherapy is that radiation offers an opportunity for in situ vaccination. So what that means is you have this high dose of SBRT. It causes a lot of cancer cell death and release of antigens from the cancer cells. If you've taken the brakes off of the immune system, you have an opportunity for the immune cells to recognize those antigens and become primed against a patient's own tumor, all within their own body. So by the time we got to this question of immunotherapy and cytoreduction with radiation, as you can see, we got really cute with our acronyms. So here we first up have the RAPPERT trial. So this combined SBRT to all metastatic sites, followed by single agent pembrolizumab. And this did show high local control, as we expect with radiation, and a median progression-free survival of about 16 months with low rates of toxicity. And now we are eagerly awaiting the completion of accrual and reporting from the Samurai and CytoShrink trials, which are evaluating SBRT to the primary, followed by immunotherapy versus just immunotherapy alone. All right, and so last but very importantly, radiotherapy is a critical modality in our toolkit for alleviating symptoms from cancer burden. Renal cell carcinoma has a propensity to spread to multiple sites in the body, and depending on the tumor location, it can have substantial impact on our patient's quality of life. So for example, renal cell carcinoma has a high propensity of developing brain metastases, and targeted intracranial control is very important because the brain is an immune-privileged space. We don't see a lot of effective immunotherapy there. And because of the blood-brain barrier, a lot of drugs don't penetrate into the brain. So these lesions can be managed with radiation alone, or depending on the location and the size of the tumor and the symptoms that it's causing. Sometimes neurosurgery will resect first, and then that's always followed by radiation. Here's an example of a CyberKnife plan, which is one of the treatment tools that we have available at UNC. And you can see here we use hundreds of beams to converge upon the tumor and give a high dose to the tumor with a very steep dose fall off. So we don't give a lot of radiation to normal, healthy brain tissue. Cord compression is an oncologic emergency where the cancer has spread to the bone or spinal canal and is compressing the cord. And this can lead to paralysis, loss of continence, numbness. And so this is, again, another area where we manage with radiation. And depending on the context, we may have surgery for decompression followed by radiation. Bone metastases themselves can be very painful. Radiation is helpful in reducing pain and also the pain medication requirements. And last, depending on the tumor location, the nature of the symptoms, the nature of the metastasis, radiation can be used to palliate pain, vascular compression, bleeding, and other symptoms. So in summary, SBRT is effective at local control of the irradiated site. In oligometastatic disease, metastasis-directed therapy using SBRT can delay the initiation of systemic therapy. In certain situations, it can even prolong the efficacy of the current line of systemic therapy. SBRT is immunostimulatory, and trials evaluating the synergy with immunotherapy and radiation are promising. Radiation can improve symptoms caused by kidney cancer, and I will echo a point that was made earlier. There are many ongoing clinical trials, and these clinical trials are essential to us being able to make progress and answer important questions, and most importantly, take better care of our patients. Thank you.